Assalamualaikum and good morning, everyone. I'm Najib from Department of Physiology, Faculty of Medicine, and welcome to Breakfast at UMHealth. For this session, I'm very grateful to introduce to you Dr. Krishnamurthy Ganesan, who is our senior lecturer, and he's also the head of Central Research Lab, Faculty of Medicine. So his research interest is mainly in regenerative medicine and osteoarthritis. So this morning he will be presenting to us on the topic osteoarthritis onset and progression, the monocyte connection. So without any further delay, I would like to invite Dr. Krishna to present his talk. Over to you, Dr. Krishna.
All right. Thank you, Prof. Najib, for your kind introduction. Let me change to a laser pointer. All right. Good morning, everyone. So today I will be presenting on osteoarthritis onset and progression, the monocyte connection. It's part of the collaboration work with University of Liverpool Medical School. Osteoarthritis, also known as OA, as in its abbreviation, is not a new disease. Evidence suggests it is an ancient disease found in dinosaur bones from approximately 100 million years ago. Today, it affects about 500 million people worldwide, with the prevalence expected to double by 2050 due to an aging and obese global population. In fact, our SPM team has reported that about 27% adult Malaysians have been suffering with OA. There are many risk factors that lead to initiations and progression of OA. As I have outlined here, it would take a day to discuss each risk factor and its possible mechanism causing OA. But however, as you guys can see that age, sex, obesity, joint injuries, and genetics can lead to the progression of OA. However, I skip this part for now. Let's move on to the next slide. The primary concern of patient visiting our UMMC ortho clinic is because of their unbearable pain, which significantly affects their activities of daily living and contributes to an increase in their years lived with disability. We recognize that current diagnostic methods for OA have several limitations. Predominantly the clinical presentation, where pain is subjective and does not always correlate with X-ray imaging. Besides that, in terms of imaging, the X-rays only show later stage signs like joint space narrowing and osteophytes, and there is often a lack of correlations between radiographs and symptoms. And to be highlighted here, the blood tests, there is no any current or specific blood tests available as a differential diagnostic marker for osteoarthritis. So basically, this leads to a common perception that nothing can be done, or that it is just your age. So therefore, a potential diagnostic tool is required as part of the differential diagnostic process, enabling the clear decision making for suitable and treatment option. Okay, let's now explore our understanding of OA. Basically, our understanding of OA is evolving. OA used to be recognized as issue of wear and tear. However, the modern finding shows that it is not simply a wear and tear disease or just a result of mechanical loading and aging. Instead, it is considerable whole joint disease in more just give me a minute. Okay, a whole joint disease which characterized by a chronic low-grade inflammation of both local and systemic origin. So it's involved the articular cartilage erosions, synovial hyperplasia, abnormal angiogenesis in the synovial tissue, synovial inflammation and infiltrations of the immune cells, and subchondral bone disturbance and ligaments and tendon instability, and also the joint stiffness. So once this had been extensively explored in OA is the synovium, which is widely recognized as a major contributor to OA progression. So this tissue lining the joint playing a key role in the inflammatory process as it comprises various immune cells, particularly macrophage, that can dictate the level of inflammations and its resolutions when there is an imbalance in homeostasis. For our patient tissue samples, we observe a significant infiltrations of immune cell, such as macrophage and the monocyte-like cell. So this observation really piqued our curiosity, especially given that OA is generally described as a low-grade inflammatory condition. We are now investigating whether this infiltration leads to the sensitizations of circulating monocyte, which is also the progenitor cells of macrophages, potentially exacerbating the inflammation and contributing to the cartilage degradations when activated chondrocytes undergo catabolic processes. So there is always a crosstalk between this activated macrophage in the synovium and the chondrocyte lining the cartilage, and this leads to the further inflammations where the cartilage breakdown happen when cartilage breakdown enzymes are upregulated. So based on these findings, our research questions is whether circulating monocytes are primed by inflammatory mediators from the synovium. Such priming could enhance monocyte migration and further exacerbate the inflammation. We hypothesized that the specific response of monocyte subtype, there are three types of monocyte known as classical, intermediate, and non-classical monocyte, which involve in various state of a role function in human body. But particularly this classical monocyte, which carries CD14 positive, CD16 negative marker, become the or can be used as a mediator from the knee synovial derived proteins of OA patients, could serve as a potential biomarker. So this would the differential diagnosis of OA, especially for asymptomatic patients in the early stage of OA progression. Let's take a quick look at our study design. Our study was designed with three main objectives. Firstly, we characterize the protein and inflammatory profile of the OA synovium, which is also we call as a OA synovial condition media, which we prepared from the OA synovium. As a baseline control, we use the as a tissue baseline control, we use the synovium harvested from the sports injury patients which undergone arthroscopic surgery and repair. And the second objective was to investigate the migration potential and inflammatory markers of monocytes in response to the tissue condition media that we feed into a transfer model, which represent our joint. So the upper well, which is represent our peripheral blood, and the lower well, which represent our local tissue. So basically, we observe the migration of the tissue from the upper well into the lower well in response to mediators that are available in the tissue condition media across a thin membrane which contain a 3 micron meter pores. And the third objective was to determine the phagocytic potential of those migrated cells, which is the ultimate role of the monocyte or macrophage as a professional phagocytic cells once it's activated. And those cells that we harvested and pre and post migrated cells, we studied their surface receptors using the flow cytometry tool. Also, we extracted the mRNA to study their gene expression, and we used the gene expression array as well as the PCR. And as a functional analysis, we performed the phagocytosis assay where the cells were treated with 1 micrometer fluorescent latex beads, and we observed the internalization of these latex beads and the numbers of latex beads internalized by per cell. All right, let's move on to our outcome. So the first objective was about to characterize the synovium that harvested from OA OA patients during the total joint replacement. So basically, we enroll 8 patients. Eight patients under the OA cohort, and then another 8 patients under the tissue baseline control, also known as TBC. So what we found from this outcome is basically we use the multi-imaging tool, a tool where we study the protein that presents in the tissue, and we found a specific protein that present in the certain wavelength masked by charges. And what we found that a particular protein, which is also known as hyanos, was correlate with the size of the protein that we found through the mass spectrophotometry. And we further validated this outcome using immunohistochemistry for the hyanos. And what we found was a significant expression of hyanos on the periphery of the synovial tissue derived from OA patient as compared to baseline control. So the multi-imaging, the hyanos expression, basically confirmed the inflammatory characteristic of the OA synovium. And then the synovium from OA patients, basically we mince the tissue and incubate in the media, and we harvest the conditioned media to study the proteins that presents in this conditioned media. And same technique we apply to TBC, the baseline control. And what we found was a 119 typical protein that present in the OA synovium as compared to tissue baseline control when we studied using the HPLC QTOF. And we found that a specific cluster of protein based on the differential protein that we found in this technique. So basically, the proteomics technique revealed the typical proteins that present in OA synovium. And we further perform or analyze this data to understand the group of protein based on the gene ontology analysis. So using the Revivo software. So what we found was proteins mainly isolated, the 190 proteins that present in the OA synovium grouped into a leukocyte-mediated immunity, acute inflammatory response, and also immune system response. So this gene ontology enrichment analysis also confirms that the OA synovium protein possesses an inflammatory profile. Let's move on to the monocyte migration potential analysis. So this conditioned media that we harvested from the OA tissue condition, OA synovium from the OA patients, we use the transfer model to understand the monocyte response to mediators that present in the tissue conditioned media using the transfer model. So what we did was basically we incubated the peripheral blood monocyte from the patients, OA patients, and then we treated with this OA conditioned media, and then we investigate the migration of this monocyte across this 3 micron well, which is I guess 3 times smaller than the average size of monocyte, which is about 10 micron. So this migration is a very specific and depends on the chemotatic factor that presents in this tissue conditioned media. And interestingly, what we found was a significant migration. Especially, you can see the cells, the big enough cells that managed to infiltrate into a 3 micron pores. This is based on a scanning electron microscopy picture. And we use MCP1, which is a standard chemotatic factor, as a positive control. And what we found from this finding was a significant migration of monocyte in response to OA conditioned media as compared to a serum-free media as a baseline control. And these monocytes that migrated, we performed the flow cytometry analysis to understand their surface receptor expression. And what we found that most of the monocytes that migrated basically presence in the within the regions of the classical monocyte, which express CD14 double positive and CD negative, CD16 negative. So this finding basically confirms that monocyte migration happened in response to mediator derived from OA synovium. And we further analyzed the monocytes that migrated in terms of its surface marker expression in the quantitative aspect. And what we found was a significant migration of classical monocyte, as I mentioned earlier, as compared to any other subtype across the serum-free media or MCP1. So this finding also further confirmed that migrated monocytes in response to mediator derived from OA synovium are predominantly of classical subtype. And then we studied a specific inflammatory markers, expression of specific inflammatory markers expression on those monocytes migrated in response to OA conditioned media. And what we found was a significant expression of CCR2 and CX3CR1, which are mainly involved in migratory property of the cells, as well as the CXCR2, suggesting that those migrated classical monocyte in response to mediator from OA synovium reveal unique inflammatory surface marker expression. And we further extract the mRNA from those migrated monocyte and studied those inflammatory genes based on the PCR array and also qPCR. And what we found was based on the PCR array, predominantly S100A8, which is alarmin, and heat shock protein and integrin proteins were significantly expressed as compared to counterparts. And when we further analyze those mRNA using qPCR for specific gene, inflammatory gene like IL-1 beta, TNF alpha, and MYD88, the 88 NFKB pathway, TLR pathway gene, and we found that a significant increase in the expression of those genes as compared to the baseline control. So this gene expression also indicates monocyte commitment to the macrophage and inflammatory profile activation. Let's move on to the third part of our study, which is we explored the monocyte phagocytic potential of those migrated monocyte in response to OA conditioned media. And what we found from our confocal imaging was those monocyte migrated in response to OA conditioned media significantly internalized the latex base. As you guys can see, the red small bubbles. So this indicate that the phagocytic role of monocyte is basically increase in response to OA synovium derived mediators. And we also studied the gene associated with the phagocytic role based on the PCR array and qPCR, as well as the flow cytometry. And what we found was those genes related to phagocytic potential were significantly expressed, as well as the CD11B markers also expressed, indicating that the migrated monocyte basically enhances a phagocytic commitment in response to OA synovium-derived mediators. So in summary, all right. So in summary, our research has identified a crucial link between the monocyte and the progression of OA. The gene expression and the flow cytometry data suggests that the monocyte commitment to a macrophage and phagocytic state is triggered by mediators from OA synovium. So this evidence points to the classical monocyte as a potential marker for osteoarthritis. Identifying these early inflammatory signals could lead to new diagnostic tools and therapeutic strategies to prevent or slow the progression of disease. We are currently conducting a preclinical animal study to further investigate this finding. So I take this opportunity to thank our collaborators from University of Liverpool, late Professor Simon Frostick and Dr. Margaret, and our universities of University Malaya collaborator and my mentor, Professor Tunku Kamarul. And I would like to thank our UMMC Auto team who keep on supporting us, providing all the samples, especially Professor Azahar, which is no longer in our UMMC, he's in a private practice, as well as Dr. Khairul and Dr. Vinesh and Prof. Fadzlina, especially Prof. Fadzlina from the total joint replacement team. Thank you, and happy to take any questions.
Okay, thank you so much, Dr. Krishna. I would like to open the session now to questions from the audience. If you want, you can write in the chat box. There is a question from Prof. David. Is the monocyte response in an obesity inflammatory marker? Do I take it then that the wear and tear is not the issue, but is it related to obesity? He's asking about obesity, and this monocyte is in response to the obesity. How would you respond to that?
All right. Thank you for the questions. I believe, yes, the monocyte can respond to the mediators that release in obese patients like adipokines. So there is another study that at the moment we are performing to understand the monocyte response to the mediators derived from the obese patients. Yes, the wear and tear basically infiltrated by the macrophage from the synovium that basically activated the macrophage and secrete all the inflammatory mediators based on the damage associated molecular pattern pathway. So this also could be one of the reason where the activation of monocyte or priming of monocyte happen in the circulation. But yes, the majority of patients, as I highlighted, beside aging, obesity is one of the factors that could be one of the co-factor, I would say, that potentially activate the monocyte migration in the synovium and further exacerbate the OA progression.
Okay. All right, another question from Prof. Tukusara. Can you tell us what are the clinical implications?
All right, thank you, Professor. So we always look at the bench to bed application. In fact, I always used to be with Dr. Chan, who left our clinical practice from UMMC. What we learned that the differential diagnostic potential, because based on the X-ray and still they cannot rule out. Sometimes the X-ray doesn't tally with the patient's symptom. But I believe that if we understand the monocyte activation in the patients in the circulation, and this can be an added value in terms of additional diagnostic marker. Just take about 3 mL of blood from the peripheral and then use the flow cytometry machines to understand whether the monocyte activated. So this will give another parameter for clinicians to make a strong decision whether what kind of intervention can be proposed to the patients. And especially at those patients at early stage, because the late stage is very clear, then the patient would go for the total joint replacement. So this biomarker would be very helpful for those patients at early stage, which the progression is already initiated, but it's not very transparent or clear based on X-ray imaging. Thank you.
Oh, yeah. Okay. And the last question I think I'd like to just asking about OA. Is it possible that OA can be a systemic disease since it's involved a lot of inflammation, local inflammation, which can spread to other organs?
Yes, of course, Prof. So the outcome that I presented is based on the knee tissue. But what we found was sometimes osteoarthritis can be found at the non-load-bearing regions like our finger joints. So this basically based on the literature, we understood that as Prof. David highlighted, the obese-related mediators like adipokines can lead to this monocyte activation and osteoarthritis at non-load bearing area. So yes.
Okay. Yeah. Okay. Thank you so much for a brilliant talk and a very nice answer that you have given to us. Okay.
Thank you.
So thank you so much for your talk this morning. So without any further delay, I would like to pass this session to surgery team, Dr. Ahmad Nazran, who will be a moderator for the next session. Okay. Thank you so much.